Thank you all for coming, and it's always an honor to have anybody show up when there's so many other good speakers talking. So I'm particularly happy that you're here. And Scott will be passing out. These are little audience interactive response devices because we're going to be very high tech today. And since we're talking about surgical innovation, this is an innovation in teaching that you may or may not like. We'll sort of see how it goes. But the idea is that we'll be able to ask questions and everyone will be able to log in their response. And then we'll actually be able to look at what the responses are. So you'll have an idea of how your thoughts on this compare or contrast with others in the room. So I might add, and it's probably not such a big deal to tell all of you, but I have to remind the medical students and the surgical residents to turn these in at the end of the day. They won't turn on your car. They're not a remote for the TV. They won't have any value for you. I have to disclose that I tell them that if you leave the room with it, it will explode. That's not true, but please do leave them so we can use them for the next time. So I'm going to share with you a little bit of background about some of what I think are important ethical issues with respect to surgical innovation. And I want to give you a little bit of background in the hope that we can then have a little bit more of a discussion. Because, if you heard me lecture for over an hour, that would be painful. That would be unethical, some might argue. So I don't want to do that. But I want to give you a little bit of background so hopefully you'll be able to see why this issue of innovation is an important one and does raise ethical concerns. In particular, what I want to focus on is the difference between innovation in medicine and innovation in surgery as sort of a subset of medicine. And then I want to focus a little bit on differences between innovation and surgical research, because these are subtle, related, but somewhat different issues and topics. And then I want to focus a little bit on oversight. So what is the appropriate oversight? What should be the appropriate oversight? Should there be any oversight? That sort of thing. So as I mentioned, this is this innovative, cutting-edge technology. For those of you who are hesitant, it's anonymous. Even if it wasn't, I don't know most of you. So unlike a classroom where I might know people and they'd say, oh, I don't want to put the wrong answer in. The other good thing about ethics is there aren't a lot of things where we can say this is the right answer and this is the wrong answer. Sometimes we can say what the wrong answer is, but we're not always sure what the right answer is. And it is completely voluntary, so if you don't want to participate, it's okay, I'll never know. So we're going to now try it out, okay? So what I would like everyone to do is yes? Oh, yeah. Do you not have one? Yeah, does anyone else not have one? Sorry about that. Sure. And so what you should do now is, take out your little device there, and this is, what best describes your highest academic degree: medical, legal, humanities, social sciences, business, or other. All right. So go ahead and
low tech. You need to add math, computation, computer science.
Oh, what?
A math, computation, or computer science.
Good point. You're right. So I did. I left out the physical sciences. So that's that other. So other. Sorry, I don't. So for those of you who are slighted by being in the other category, my apologies. I will try to do better with the additional questions, although I have a feeling that this may be a continuing issue. But luckily, I won't be asking this question very frequently. So now, you'll see there's a little countdown. So you can vote before the little timer comes on, but when the timer gets to 0, the polling is closed. You see that in the upper right? So if you want to vote, you have to vote before the timer gets to 0. Okay? And as soon as it comes up there, you can log in your vote. So, and the other thing is, despite the fact that we're in Chicago, you can only vote once. So you can keep pressing the button, but it only logs in one vote. All right? So Yes.
You can't change it.
Yes.
Says login. Does that mean we have to press?
No, you don't have to do it. No, you just 1, 2, 3, 4, 5, 6. Yes.
Does it take
But
the
that
first
means you
and last
cannot
one to
change your.
It takes the first thing you press.
So think carefully.
Yes. All right. And just to see, okay, so just to give you a sense of the people in the room, all right, so 25% with a medical, 4% legal, 13% humanities, 17% social sciences, 4% business, and probably many of the other are those physical sciences, math, computation that I unwisely left out. So, yeah. Well, for those of you who log in, I don't know what that would, well, actually, that probably doesn't count since that's not a choice on this particular one. So anyway, that's just to get you warmed up. So now, what best describes the field of your current job? Again, just to get comfortable with this, I'm only giving you 5 seconds now because everybody's so good at it. All right, so yeah, so as soon as it comes up, I'll give you more warning. All right, so next time before I hit the countdown, I'll read the choices. Okay, so anyway, so lots of people with a medical type of background, which may or may not be good. So now, have you ever been involved in human subjects research as a researcher or as a subject? So the choices are 1, yes, 2, no. I did not put an unsure because I thought this would be one where people would know. So go ahead and vote. You've got now 5 seconds. To the best of your knowledge, exactly. And there's, you're not under oath, so actually we had 26 responses that time, so we're getting better. All right, so 69% said yes and 31% said no. So, and for those of you who are involved in computational sciences / math and that sort of thing, you'll notice, and I just want to note this up front since my sister and brother-in-law are biostatisticians, these scales aren't really accurate. And so if you look at that and say, that really doesn't look like 31%, it's not. So it's just a picture to give us something to look at, okay? All right. So now you know how to use this, so you can put it away for a few minutes. There won't be any sneak questions, but I'll let you know when one is coming up. So just to give you a little bit of background, when you think about new medications or new drugs, new drug is developed or discovered, okay, and it then is studied in clinical trials. And after some data is accumulated, an application is made to the Food and Drug Administration, the FDA, for approval of the drug for a specific use. And that is the use for which it was studied. Other uses that are not FDA approved would need to be disclosed to a patient. If a doctor said, okay, here's a drug here's a drug that works for high blood pressure, but lo and behold, doctor says, well, I've also found that it's helpful in reducing cholesterol in my patients, and I want to start prescribing it to do that. Doctors can do that. They can prescribe it for anything they want to, but if it's not FDA approved, they're supposed to disclose that to the patient, and the insurance company may not cover it. All right? So it's a very, very rigorous system for new drugs. And the FDA has a tremendous amount of oversight, and there's a lot of money that's spent on developing things. So in comparison, yes?
When you use the word must,
yes.
Are you implying medical legal issues?
Let me see how I used it.
Must be disclosed.
Must be disclosed.
By law? Or ethical issues?
Well, by law, it's supposed to be disclosed.
So medical legal?
Yes. In this instance, yes. You're a tough audience, but that's a good question. Yeah, and please feel free to interrupt me with any questions at all, because, I have some background, but I really would like this not to be a lecture. So, in comparison to new drugs, there is no FDA for a new operation. And so what that means is a surgeon who thinks an operation could be done in a better way has absolutely no oversight whatsoever. A surgeon can do whatever he or she wants to in the operating room as long as it is to benefit the patient. Yes?
In the business of hip operations, I know there are new ways of doing it. Does the FDA approve the substance, the development of the device?
Yes. Yes. So, and that's a very important distinction. So devices are in fact regulated, but the procedure is not. So if someone says, I have a new device, well, that has to be approved, and there's a whole process for that. But if you just say, I've got a new operation, I have a new way of doing it with the same device, there's no oversight of that. All right? So that sort of that's the reason why there's an issue here and why we can't just go to the FDA. Now, what are the benefits of a lack of oversight? Historically, the freedom of surgeons to innovate has led to lots and lots of improvements in patient care. And as an example, I would ask you to think about what it would have been like to have a cholecystectomy or a removal of a gallbladder performed in the 1950s compared to now. And so just to, yeah, so and this is the way I'm going to help you to think about that. So this is a typical operating room, early 1950s, and a couple things to notice. So I even have a laser pointer here, and I think I can use it, yes. So the lights, so notice the lights, notice the gowns, notice the fact that they're all men, notice that they're looking down at the patient on whom they are operating, okay? And I don't know if you can gather it, but this is not a huge room, okay? Now, the instruments are all laid out here, and the surgeon has made an incision. You can't see it, and I have deliberately tried to not be overly graphic with my photographs, since some of you don't like that or may not like that. Now, in comparison, this is a patient. Let me just turn the lights down more. Does that help?
Yeah.
Okay. You want it down more? No, that's good? Okay. So in comparison now, a patient, here's the patient, having the gallbladder removed today. Most of these operations are done laparoscopically, which means the surgeon and everybody is looking at the screen. They're not even looking at the patient. There's a camera that's through the abdominal wall. All of the instruments are long instruments that allow the surgeon and the assistant to work inside the patient. But the lights are different. If you can, I don't know if you can gather it, it's a much bigger space. The anesthesia equipment, which you couldn't even see in the other one, is this whole set of monitors over here. And not to mention, okay, there's women in the operating room. We are using disposable masks, gowns, hats, shoe covers. The instruments are here, which are very, very dark. You can't see, but they're quite different. They're very long to allow them to go through the ports so the surgeon can do this operation. So tremendous number of differences. Now, is this good or is this bad? Well, if you had your gallbladder taken out in the 1950s, traditionally you would have a great big incision running the length of your rib cage just underneath the ribs on the right side, and you'd probably have spent 4 to 7 days in the hospital, at least. Okay. So I wasn't practicing surgery in the 50s. I wasn't alive. So all I'm telling you is what I've gathered from others. My father's general surgeon. He was in practice. So big changes, and I would argue tremendous benefits. So these changes, these innovations have been advances for patients. They've made the surgery better, easier to recover from, that sort of thing. So a couple other things to notice about innovation. And this is something that I mentioned sort of as an aside, but I think it's hard to avoid noticing how important it is, and that is that innovation absolutely sells. And so it's great for marketing. Everything you'll see, I mean, you think about it, everything's new and improved. It's not just new, okay? Because that's not good enough. It's new and improved. And the assumption is that innovation is better. And in medical care in general and in surgery especially, we love innovation. And in fact, if you look at the University of Chicago Department of Surgery website, right, we are the University of Chicago at the forefront of medicine. That's our tagline, okay? Which,
That's not the website.
pardon me?
That's not the website. University of Chicago at the forefront of medicine.
That's on the website. Yes, on the website. You are a tough crowd. All right. So, and I'm quoting now, the University of Chicago has a distinguished history of surgical innovation and remarkable strengths in digestive disease, gastrointestinal surgery, and cancer. It sort of goes on and on. So it's right there in the very first sentence, surgical innovation. And this is this whole idea of being at the cutting edge. So I think, again, just to note, innovation is seen in general as being good, because a change isn't considered innovation unless it's sort of a positive change. And patients want surgeons in general to be innovative, and patients and surgeons want to be at the cutting edge, and new technology just in general, especially in surgery, has a big appeal. So let me give you a little bit of one other historical example, and it's an example that I know a lot more about. So I am, as was mentioned, I'm an endocrine surgeon, which means I do thyroid, parathyroid, adrenal operations primarily. And so the most common operations I do are thyroidectomies and parathyroidectomies. So thyroid surgery has a long history, and many of you are familiar with this painting. It's the Gross Clinic. The painting is by Thomas Eakins. Samuel Gross is the surgeon who's depicted. And this is Dr. Gross's operating room. Now, we didn't actually mention the differences between an operating room then and an operating room now, which are even more dramatic. But again, that sort of takes us a little further afield. But Dr. Gross was a very influential surgeon, and he wrote a textbook of surgery in 1866, and he said about thyroid surgery, thus, whether we view this operation in relation to the difficulties which must necessarily attend its execution, or with reference to the severity of the subsequent inflammation, it is equally deserving of rebuke and condemnation. No honest and sensible surgeon, it seems to me, would ever engage in it. And if you weren't really sure how he felt about it, he went on to say, can a thyroid gland, when in a state of enlargement, be removed with a reasonable hope of saving the patient? Experience emphatically answers no. If a surgeon should be so adventurous or foolhardy as to undertake the enterprise, I shall not envy him. Every stroke of the knife will be followed by a torrent of blood, and lucky will it be for him if his victim live long enough to enable him to finish his horrid butchery. Now, a couple things to reflect on. First of all, if any of you have read anything in the medical literature, we just don't get this kind of writing these days. You know, you don't read about torrents of blood and horrid butchery, and it's all very scientific. The other thing to notice is that things have changed. I've done about 2,000 thyroidectomies. Knock on wood, I've never had to give a blood transfusion. So things are different. We can do the operation now. It's a lot safer for many reasons. Yes?
Low-tech comment.
Yes?
This is from the perspective of the patient. Medical literature is never now from the perspective of the patient in my limited experience.
Sure. No, I think that's a very good. So her comment was that this is written from the perspective of the patient, whereas nowadays there's very little written from the perspective of the patient. Now, what's fascinating, I think that you raise an interesting point, which is that this is written by a surgeon, in fact, a leading surgical educator, but it was much harder to not adopt the patient's perspective then, I think, than it is now. And maybe that has something to do with that, but a very good point. So, obviously things change, and I would argue that this is an advance. This is an innovation that's a good thing. Thyroidectomy today, quite different. And so most of the time, I would argue, patients benefit from this type of surgical innovation. Well, what about innovations that aren't so good? What about things that people tried that didn't work out so well? So prefrontal lobotomy was used to treat lots of things, most of which it did not work for. It was very common. Internal mammary artery ligation. So the internal mammary artery is an artery that runs in your chest, in the chest wall. And so there was an idea that, well, if you have angina and you divide or tie off that blood vessel, that more blood flow will go to your heart. It seemed to make some sense anatomically, and lots of patients had it done. It doesn't work. It doesn't help anything. Another one, gastric freezing for ulcer disease. Is anyone familiar with this? So a few of you. So you know, my colleague and good friend, Dr. Ed Kaplan, tells me when he was training, this was all the rage, gastric freezing. And he was at the University of Pennsylvania, and they got the latest and greatest gastric freezing device. It was the newest technology. Unfortunately, it has no benefit. It doesn't help patients. So sometimes it's hard to know if something that the doctors feel like it makes sense, seems like a good idea, is actually going to pan out to be valuable or not. And another example, locally in Chicago, there was a time when infants with big thymuses were irradiated. And in fact, now we know that's actually not a good idea. In fact, it's led to many hundreds of thousands of cases of thyroid cancer. I operate on lots of people because their thyroids were irradiated years ago. And it was all, they were getting the best medical care at the time. Again, unfortunately, it turns out it's not a good idea. So part of the difficulty is understanding which of these two possibilities is actually occurring. So these are the two possibilities as I see it. It could be, yes?
Quick question. So is the radiation considered a surgical operation?
No. So radiation would not be. So I move a little bit afield from surgery just to point out that many things in medicine that we think are good aren't good. Yeah, but no, I would count radiation as a non-surgical treatment. Currently it is. Well, it's regulated by the Nuclear Regulatory Commission. Yeah, so it's a little bit different. But anyway, it is regulated. Yes?
Well, maybe jumping ahead, but you're almost saying that the medical profession itself doesn't have a means of overseeing any of this, or the court system, it's only the court system that does it.
Well, I guess I wouldn't.
That's where you have to argue. Of course, people will say that's medical practice, but it's a jury that will say that doesn't sound so good to me.
Right. Well, no, it's a good question. I guess I would not want to argue that the court system is the best way to decide if something's good medical practice or not. So let me see. Maybe come back to this in a few minutes and see if that is a different alternative, because I haven't really talked about the legal process and malpractice and that sort of thing. But that's an important comment.
Implicitly by saying that no one has to okay.
Right.
Other than maybe the people in the hospital.
Right. Yes.
I think for the people who are not medically oriented in the audience,
yes,
you should reiterate what the first law of medicine is.
Okay.
No nocere.
Okay. So first, do no harm. All right. So
we're supposed to have an internal system for regulating ourselves.
Right.
As physicians.
Right. And I do think, that's an excellent point, but I think with all of these new ideas, new technology, I have to assume that the people who were proposing them at the time were absolutely convinced that they were doing good for their patients. And so I think that, you have to almost assume that people thought that this was beneficial. It just turns out that it wasn't. And so part of the difficulty is we sometimes think something's a great idea, and we promote it, and we have lots of patients that have it done, and then in retrospect we realize, it wasn't such a great idea.
Well, you don't know until you have a statistically significant database. physician can't make a judgment on it.
True. And some of the things that we do don't get studied until after they've been done on thousands and thousands of patients. So absolutely.
You don't have any guarantees.
And then you don't have any guarantees, right? And
May or may not be.
correct. And it becomes even more complicated with surgery, I think, because unlike a clinical trial where you can compare this drug versus this drug or this drug versus a placebo, when you're comparing an operation, there's a lot of individual variation in how surgeons do each operation. And even people who are trained at the same place by the same people have different skill levels and different ideas about what makes a good operation. So absolutely, that's very difficult. Yes?
I don't know, but isn't there some mechanism of obtaining informed consent before people go in for surgery?
Absolutely.
So they should be apprised of the risks that are involved with whether or not it's a new treatment or a possible new...
Yes. Yeah. And we'll get to that, but absolutely. So informed consent's a critical part of this. So nobody goes into the operating room without being informed. But unfortunately, if the presupposition by the person who's doing the operation is that it works, then they're going to inform the patient, well, I'm giving you the latest and greatest treatment. Yes?
I also, the informed consent, a few times I've gone in procedures. You get the information assigned that, hi, you got the IV running. You're lying there. You've been completely prepped. Now you're given the information and you're supposed to decide whether or not it's a good idea and say, no, thank you, take everything out and going home.
Well, hopefully it doesn't happen that way all the time. So sometimes it does, you're right. Sometimes it does. But
That's when they did it for the colonoscopy. That's when they did it for the wisdom tooth.
well, I mean, most of my patients are going to come and see me for, let's say they have a thyroid nodule. And let's say they had a biopsy and the biopsy shows that it's cancer. Now they need their thyroid taken out. That's a very common situation. So I'll see that patient. I'll explain the risks. They'll sign a consent form, and then they'll go home. And then they'll come back on the day of surgery and have their operation. So usually it's separated from the procedure. But anyway.
You've not run into anywhere it was separated.
Pardon me? You haven't?
No.
Okay. Well, so it doesn't always happen that way. Yes?
Maybe you'll have occasion, I know you didn't plan it this way, to compare at least, I don't know if you could differentiate.
Right.
These situations from a fellow selling a derivative on a basket of securities, saying this derivative is going to make you safer. This derivative is going to make you safer. And we tested it out. This is the statistical story as far as we can know.
Mm-hmm.
So, yes.
Yeah, I guess, and maybe it is similar to that. I'm not sure. I mean, it's a very good... Right. I mean, it's worthwhile considering. I think part of the difficulty is that so much in medicine, the presupposition is that it's based on science. And so... Okay. I don't know enough about business to be able to...
Hotshot physicists who did all kinds of statistical investigations and went 20 years in the past to tell you that that's the way it works.
All right. Well, so we'll keep that as a comparison. So I was saying two possibilities as I see it. So patients may be, if we have a lot of oversight, patients may be prevented from getting the latest and greatest treatment options because of restrictive oversight. So if there's a lot of oversight, they won't get what they should get. The alternative is that patients are being subjected to greater risks because innovative techniques may not be well understood or, in fact, be effective. Right? So two possibilities. Another way of looking at it is this tension. Should we be encouraging more new technology and innovation to help more patients? Or should we be protecting patients from the unbridled enthusiasm of surgical innovators? So it depends on how you look at the world. It depends on how much you trust doctors or surgeons. And so when I talk to people in ethics about this, depending on their perspective in the world, they answer these questions very differently. So let me give you then one attempt at trying to give some degree of distinction and oversight for these things, and then we're going to try these out with some cases. So the Society of University Surgeons, which is a pretty well-respected surgical group, put together a task force to consider how do we provide some clarification and oversight. So they decided that there should actually be 3 categories. Category number 1, minor modifications of a procedure. That some people call this tinkering, okay? So I was on the task force. We decided tinkering is not a really good idea. I mean, we shouldn't write, I mean, then it sounds like surgeons are in the OR kind of, fooling around, right? So that's not what we used, okay? So tinkering is just, right? So that's a shorthand way of thinking about it. And I'll give you some examples so you know what I mean. But so these are generally unplanned, right? So you're faced with something, you're like, I always do it this way, but it seems like it would work better if I tweaked it a little bit, did it a slightly different way, and it will work better in this patient. That we would consider a minor modification of an already accepted procedure. In contrast, then, another category, an innovative procedure. It's a new or modified procedure that differs from currently accepted local practice, all right? And then the final category is research. Research is a systematic investigation designed to develop or contribute to generalizable knowledge. Now, that description, this third definition of research, is right from the NIH Code of Federal Regulations, all right? And
So the research is not intended to benefit the patient per se.
Exactly. So it may be a side effect, but the primary goal of research is to gather knowledge. Now, if patients participate in clinical research, there's a tremendous amount of informed consent, and that's that informed consent process is quite different from the informed consent process for treatment. So that's consent for research, and so there's much higher standards for that. So in terms of these different categories then, one issue has to do with defining them, which we'll see some problems with that. Another has to do with disclosure. So how much do you have to explain to patients about this being new or different? And then finally, how much oversight should there be? Should we have people checking up on this? Should there be regulation? That sort of thing. So again, going back to the SUS position, informed consent should ensure patient understanding of a procedure, but a minor modification need not be specifically discussed. So if a surgeon says, well, I'm planning on taking out your thyroid, and I'm going to use absorbable stitches instead of permanent stitches, I don't have to disclose that to you. I don't have to get your consent for that. That's a minor modification. That's sort of within my decision-making. I don't have to involve you at all in that. On the other hand, the suggestion is that in that second category, innovation, it should be disclosed in the informed consent process if it's planned. And if it was unplanned innovation, then it should be disclosed immediately afterwards. All right? So again, the idea being if you do something that's really different, the patient should know about that. And then finally, they said if a procedure has not been described in a North American surgical text, it is innovation and should be discussed with the patient. Now, many people have said, well, that's I'm sorry? In advance. In advance, absolutely, yes. So many people argue that, well, this is, North America, we're not really the arbiters of everything that's good in surgery, and that, perhaps this is a very Anglo-centric view. Yes, sir.
The surgical text should be indicated in which generation it was published.
Sure, that's true. Yes, I guess that's true. Maybe.
That would only apply to
Yeah.
Okay, if it's in the 1951 and not in the anything published in 2000, maybe you have to discuss it, but generally.
Right.
Just because, aside from that, I wouldn't think that which issue it's in makes a difference.
Yeah, maybe a current surgical text. Even that, though, people might argue that textbooks lag behind. So, some people would say, well, if it's been described in a surgical journal, if it's been published, well, then maybe it's not so innovative. So again, the distinctions are sometimes a little bit hard to make. Research, again, just to emphasize the difference, systematic investigation to contribute to generalizable knowledge. Also, human subjects research should be reviewed by an institutional review board. Now, again, just a couple seconds about IRBs. IRBs are very specific, defined by federal regulations, who has to be on it, what has to be in the consent form. This is a highly regulated system once you move into research, right? So in contrast to anything goes in the operating room, research is sort of the other end of the extreme. So I would say when this came out, much like the Supreme Court said about pornography, you can't define it, but we know it when we see it. So people said, well, these distinctions aren't so good. But again, to give you some examples, in the operating room, a minor modification or tinkering, if a surgeon said, well, I usually put the intestine together by sewing it together, but I'm going to use a stapler, very well established, lots of surgeons use it, it's considered acceptable, it's not new, but that choice would be that minor modification. Nobody has to talk about it with the patients. An innovative procedure, if you said, well, we're going to use radiofrequency ablation to get rid of thyroid nodules. Now, nobody does that. It's never been written about. I just thought of it when I was making this slide. Right? Truly, I would say this is a bad idea if you ask me, but if someone said, well, I think maybe we should try it. Who knows? Maybe it'll work. That would be kind of way out there, but that would be innovation. Or surgical research. So if we said, well, we're going to compare doing an operation through the front laparoscopically or through the back endoscopically, and we're going to randomize patients. One group we're going to do it one way, one group we're going to do another way. We're going to compare the outcomes. Everybody would agree that's research, right? So, of course, patients have to know that they're participating. They have to agree to participate, all of that. But it's clearly a different category. So let me give you a case now so we can try out these distinctions. So I'll read it to you because it's kind of long. Dr. Dan Cahill works at a large university hospital in the Southwest where he commonly sees patients with an uncommon malignancy. He's identified a new surgical method that he believes will help in removing this type of cancer from unusual locations. This approach is a modification of approaches used in other organ systems. He has found no discussion of this approach for this specific cancer in the surgical literature. He believes that over the course of the next 2 or 3 years, he will see approximately 10 patients who might be eligible for this proposed treatment. He believes that the new method will be at least no worse than other approaches a surgeon might use in the same type of cancer in a similar patient. Okay, so that's the background. So, do you believe that what Dr. Cahill is planning to do is simply a modification of acceptable techniques or formal research? So our choices are number 1, modification of acceptable techniques, number 2, formal research, or number 3, not sure or undecided. So you have 5 seconds now to answer. All right, so 57% said surgical modification of acceptable techniques, 22% said formal research, and 22% said not sure. So, yes?
There didn't seem to be a tinkering option.
There wasn't a tinkering option. Right. Would you have gone for tinkering?
I would have gone for innovation, but that seemed more like, one sounded more like tinkering.
Ah, okay. All right. So perhaps not a well-worded question. Well, let's go on to another question. Do you believe Dr. Cahill has any responsibility to advise patients that he proposes to use an innovative technique in their treatment? Yes, no, or unsure or undecided. So you have 5 seconds to answer. So mostly yes. So, and I have to say that these results sort of fit along the lines of what, when I've asked these questions of groups of surgeons and surgical researchers, pretty similar with a fair degree of split between whether it's research or not research, but pretty much, pretty high degree of agreement that you've got to discuss it with the patient either way. So, another question. do you believe Dr. Cahill has the responsibility to seek prior review and approval before he offers this treatment to patients? So this is a different thing, prior review and approval. Okay, you've got 5 seconds. Everybody's voted? So 75% said yes. 13% said no, yes.
Prior approval from whom?
That's a good question.
Responsibility, meaning legal responsibility or ethical responsibility?
Yeah, that's a good question too. So right now,
Answer which way I was going to vote on.
okay.
Legal.
All right. So let me ask you this. So ethically, and now just, is anyone in the room an attorney? Don't be shy. Raise your hand. Okay. All right. So a few of you now I say that. I mean, my wife's an attorney. Okay. So one of the things I've learned is to never say anything from a legal point of view. Right. So she said, don't opine on the law. You're not qualified. Okay. So I'm not opining on the law. All right. So I'm going to give you. So I would say this is ethical responsibility. Okay. I know. You're right. So. Now, the other question was, who should give this review? So there's a majority of people who feel that there should be some prior review and approval, but we don't really have a good mechanism for that. Yes?
The problem with it is that if this is a new procedure, you can't find it in the textbook.
Right.
As you say, who would give it approval? Anybody else should ask, well, no, we don't do that. It's going to be a turn down immediately.
Right. And exactly is one of the problems, that if you say, well, we got this new idea, if you go to any of the local hospitals, they're going to say, no, we don't do that. Yes?
Are there ways of answering these ethical questions that look at the negative impact if something goes wrong? Are there established ways that Dr. Cahill should be using to say, in this particular case, while it isn't tinkering and it's not quite research, it could be really dangerous. So, I mean, it seems very
Sure.
To the earlier statement, he said
Right.
that he's already decided it's not dangerous, there won't be any worse than.
Yeah.
He has concluded that.
Yeah. I mean, but I think, yeah. But I think you have to, yeah. So that's a critical thing. Yes, sir.
Well, I'm a physician, and I can tell you that if somebody did some crazy operation at my hospital, St. Joe here in Chicago, in Illinois, it's been long established since the 70s that if something nuts happened, and let's say this patient died or was crippled or something, you took his stomach out through his mouth or some crazy thing, the hospital would be on the hook. And so the hospital would say, sister, what the hell do you think you're doing? No, you can't do that here. We don't want to be on the hook for something that could go wrong. This is a very complicated matter, and there are legal overtones.
Yes, yeah, there are. And so one of the, and with respect to the hospital oversight, so one of the possibilities that institutions have said is, well, in order to do something, you need privileges for it. And so in order to have privileges, you have to go to the hospital credentials committee to get privileges for a procedure. Now, it's difficult because if you're a good salesman and you say, I got this great operation and nobody's doing it, but I'm going to be the one, and it's going to bring scores of patients to our hospital, and it's very safe, depending on the credentials committee, you may have them go along with almost anything. Now, and I, you know, I don't want to say that the committee would not provide a fair amount of oversight, but sometimes that, I guess the quality of that oversight is questionable. Again, because the people on the committee may have no more background than the patient that maybe is given consent for this. Okay? So these are really important questions. Yes?
So I'm a software engineer, and in our business, usually the programs we write don't have life and death consequences, but whatever knows, sometimes they do.
Right.
And what we commonly do, we have procedures to have peers review our designs, for example.
Right.
And they don't have the authority to tell us you can't do it that way, but we appreciate the possibility they might discover something we didn't notice, even if they've never written such a piece of code before.
Yeah, and I think that's a really good point. And what is commonly done, it's not really formalized, but what is commonly done in, let's say I had some bizarre idea. I would generally go to my colleagues in the surgery department and say, hey, I have this idea. Is this crazy? Have you ever heard of this? Has anyone ever tried this? I once had a great idea and realized that nobody else had done it, and so, when I studied it, it's because it's a really bad idea. It doesn't work. And so sometimes the informal interaction with your colleagues is done. No question that that's done. But as you say, they don't necessarily have any authority to say you can't do it.
But before you do that,
yes,
you better write a letter in the journal expressing your idea, because if you don't, your colleague's going to say, yeah, well, maybe. And you'll get you to publish it.
Yeah. So that's a good point. Yeah, and that does mean it raises some concern about the competitive nature of something that is new and innovative. Because if it really is a great idea, everybody's going to want to take credit for it. If it's a really bad idea, no one's going to want to take credit. So it's a tough situation. So let me give you another case. So this is a case that I'm going to just describe to you. And this is a patient who has and this is real, so I'm not making this up. So there's a patient who has a medical condition that I had not heard of before, where part of his adrenal gland is overactive, part of it's okay. And so he needs to be on medications constantly. And so he said to me, he found me somehow, I don't know how. He found me, sent me an email, and then called me up. And so now we've had this ongoing dialogue now for the last 5 to 7 years, where he keeps coming up with all this new research and wants me to review it and stuff. So he's got a lot of time on his hands. So what he wants is for a surgeon, me, to do a laparoscopic operation where, without making a big incision, I will go in with a laparoscope, open his adrenal gland, take out the central portion of his adrenal gland, and leave the outside. So take out the medulla, leave the cortex, for those of you who are in medicine. Okay? Now, people have described this as taking the jelly out of a peanut butter and jelly sandwich laparoscopically. So now I have said, well, I don't think that that's a good idea for a lot of reasons. And I explained to him, and I said, I really, number one, I don't think it would work. Right? Number two, I don't think it would be safe. Number three, I think that, for me to take you, who, you have a condition that's currently treatable. I mean, you're okay. Your quality of life may not be great, but you're not dying of this. And to put you through an operation that's potentially life-threatening so that you can get off medications seems like a bad idea. And yet he keeps coming back to me. And I keep saying, well, I'm just not that skilled laparoscopically. Perhaps you should talk to the guys at, because they're really good. So I guess my question is, how do you think, let's assume that I could get to the point where I thought it was safe, right? Where I could safely do it without a significant risk. And I was able to ensure that he was giving me consent. And, as far as informed consent goes, this is better than anything because he's done all this background research. He said to me, did you know that in Sweden in the 1920s, they took the adrenal medulla out of rats? I said, not only did I not know that, but how do you know that? And he said, well, I, looked up this and that and the other place. And so it's kind of a bizarre relationship I have with this patient. But in terms of informed consent, it doesn't get any better than this. So I guess my question for you, I have a number of questions, but let's ask this one, and then we can talk about it further. How should we characterize this new operation? Should we characterize this as a modification of accepted technique or tinkering, okay, to just make sure that that's in there? Number 2, surgical innovation. Number 3, surgical research. Or number 4, you have no idea. So you have 5 seconds from now to answer. All right, so now, does anyone want to make any comments before we see what the voting is?
Well,
Yes.
what is accepted technique? You haven't told us that.
So for this, I mean, the accepted technique would be, laparoscopic, removing adrenal glands laparoscopically is well accepted, entirely well accepted. Removing parts of the adrenal gland laparoscopically is not well accepted, right? So it would be a modification, but is it so much of a modification that it's innovation, or is it in fact so far removed that it's research? Is kind of the question.
Don't you have to have a comparison study and all, et cetera, et cetera?
Well, so it's interesting, and this gets to the point that the gentleman in the back made, which is that doctors, anyone involved in the sciences, if you're the first one to do something, you generally want to write about it. And so this patient even said to me, if you do this and it's successful, think of how well known you would be. You could help lots of patients. You could write all about it. You'll be the world's expert.
That's just a tactic on his part.
Absolutely. But it appeals to my ego. Yeah, exactly. But I'm a surgeon, so I have a big ego. So, yes.
But I would want to know whether this could be done in pieces.
Right.
Whether you could continue to do the accepted,
Right.
the accepted way.
Sure. Yeah. So that's a good question, and it is, So I had said, well, you could try doing it on one adrenal gland, and if that doesn't work, at least you'd have the other adrenal gland. So yeah, it could be done part way. The other question is, well, if you were really, and this is where it becomes difficult because the specifics of the case become somewhat overwhelming, and so I've tried to streamline those. But it's also an interesting question that if I just took out both of this gentleman's adrenal glands, which I could do laparoscopically with very little problem, I would solve his problem. Now, I would create a different problem, which is that he doesn't have an adrenal gland, and he would have to be on hormones. But I could solve it with completely accepted techniques. And so really the only reason to do something beyond that is that he really wants me to.
Because he doesn't want to take drugs at all.
He doesn't want to take drugs, and he doesn't want to have a big incision. And again, I think that what this raises is part of most of the cases that we've talked about, it's the surgeon who has sort of pushed an idea. This is a great idea. It's new technology, whatever. Sometimes now, and especially today, in the era of minimally invasive surgery, patients are pushing things because they want the surgeons to be minimally invasive. It's fascinating. So are any of you in gastroenterology or cardiology? So, all right, so I don't want to offend anyone. So it's fascinating to me that surgeons today all want to be minimally invasive. We want to be the minimally invasive surgeon, right? And that's where you see all these minimally invasive surgery center. It's on all kinds of advertisements. In contrast, cardiologists and gastroenterologists all want to be invasive. They want to be the invasive cardiologist or the invasive gastroenterologist because they do more, right? Surgeons want to do less. So I'm not sure why that is. But anyway, let's look at the results. So very few felt that it was a modification of accepted technique. So very few with tinkering, 35% surgical innovation, 50% surgical research, and 12% not sure. So I would say that with this case, I agree with those who are not sure. I'm truly not sure. Now, the other question, though, which a few people have raised with respect to other cases is, let's say I really wanted oversight. Let's say I wanted someone to give me some stamp of approval. Who do I talk to? Because most people, if I explain this to them, they're going to say, you're crazy. Why would you do this? You're letting this guy appeal to your ego. Now, the fascinating thing, just as an aside, I have never met this gentleman. He's never come to see me. He sends me emails. He calls me. He sends me PDFs of articles. He sent me a CD with 50 pages worth of research on it. And so all along I've said, well, you really need to be evaluated, and you need to see the endocrinologist. There's lots of things. That's never happened. So I'm pretty sure this gentleman's not ever going to have an operation. Yes?
Have you considered that it may benefit him psychologically? I mean, it sounds like it's kind of verging on an obsession, and maybe if you could say, well, there are these risks here, but he's going to have this benefit where now he's satisfied, whatever
Right.
the outcome is, he's not going to be
Sure.
obsessing over this.
Yeah. No, it's a great point. So I've thought about, is the fact that we have this ongoing relationship, is that in fact beneficial? Or is it, as you suggested, is there perhaps a potential psychological benefit that would outweigh these medical surgical risks? And that becomes a really tough one, because often, as we'll get to in just a minute because we're running out of time, often the question is how much weight to give to that psychological benefit for the patients, and how much should that play in our decision making? Yes, sir.
This is curious. If I were an FBI man wanting to entrap somebody who wants to make bombs for Iranians,
Yes.
This is how I'd go about it. I've never met him. I've never met the guy. Met you, and I'm waiting for you to bite.
Yeah.
Why do you say he's your patient if you've never met
Yeah,
him?
no, that's a really good point. So he's truly not my patient because I don't have a doctor-patient relationship with him. He is a patient who has sought advice. But you're absolutely right. He is not my patient and I don't have a doctor-patient relationship with him. And so I feel that I could, at any time, simply stop answering his phone calls. I could simply stop answering my emails. Absolutely, I could.
But it's not. I can't imagine that you consider it to be proper for you to give any advice in this situation.
Well, that's an interesting question, and I've talked about this with some of my colleagues.
Because you're accepting his analysis of his situation,
Right.
his presentation
Sure.
of his facts, both of which may be flawed.
Absolutely.
Well, that's not exactly the correct. He's sending him the research instead of saying, well, what do you think about this research? So
Right.
He's giving from a more, having had the background in science, he can say, that research is just plain bogus because
Right.
of this, or, oh, that's interesting research.
But the,
Sure.
But the crucial thing, it seems to me, is what is the patient really?
Yeah.
What is his condition? What is his problem?
Sure.
Not what people have done research about.
Right.
No, he's looking for the research in it, and he's looking for him for information on that research, in a sense.
Yeah, I mean, I
If you
think...
wanted to diagnose his condition, he'd go into him himself. That's not what he's looking for.
He's trying to
Well,
get
what's the patient's medical?
I mean, he's got a doctor, he's being treated with medication.
He's trying to get into research.
Right. No, he is. Right. He has a doctor, and he is being treated. I mean, I think that... Oh, yeah, that's true. I only know what he tells me. That's true. That's true. But there again, I mean, I'm not giving him medical advice in the sense that I'm not... No, not yet. And in fact, I won't because, I haven't seen him.
Or he's considering to go ahead with the surgery. Clearly, he's going to see him before he
Oh, yeah,
takes off.
yeah. Well, I can tell you, I mean, I can tell you just as an aside, just so that you don't, write to the state medical licensing. I'm not going to operate on this patient case, so just to be clear. So let me ask you this question. Assuming that this is a reasonable surgical option, how should I respond to the patient's request for an innovative procedure? So my choices are obtain IRB approval before moving forward, simply inform the patient and obtain consent, institutional review board, that's the research review board, or seek oversight from some other group or body besides the IRB. Yes?
Could you describe anything about this other group or body?
Yeah, well, at this point, there is no other group or body.
Perhaps number 3 isn't the best choice.
Yeah, well, no, it's so.
For other areas of surgery.
Right. Yeah. So the Society for University Surgeons, in our white paper on this topic, we said there should be innovative surgical committees in every department to consider these things. And that would be the type of thing. So some other group other than the Research Review Board. All right? So given that background, you have 5 seconds to vote. Okay, so 53% go with that, and 37% said IRB approval. I'm not sure how much time to spend on this. Yes.
I would just say that one of the things you could do is talk it over with your chief of surgery.
Right.
Because if the shit hits the fan, he better know about this.
Absolutely. Yes.
Do you want to have a warfare?
Yeah. No question. Yeah. Job security demands that. Yes. Yeah. Yes.
Oh, I was just going to point out that I would have picked option 2, but I actually picked 1 with the IRB because if you do ever want to publish, it better have been IRB approved.
Yes, so that's true. Yeah, no, that is true. And it is an interesting thing that even, like, if you do something, let's say I do something 5 times one way, and I decide, ooh, that's a really good way. Now I want to write about it. Then I actually have to get IRB approval for a retrospective study of the 5 patients that I already did. Yes.
Retrospective wouldn't be as strong as your prospective.
Absolutely. Yeah. So I guess, let me just, and I won't spend a lot of time, there is an approach now to doing thyroid surgery. So with thyroid surgery, we make a little incision in the neck and, we do the operation. So there's an approach that's been described, more widely done in the Far East than here. It's through the armpit, through the axilla. And now the latest and greatest is robotic assisted. So robotic, if you do anything robotic assisted, it must be better. That's what I gather from the billboards. I'm sorry. With robotic assistance, depends on the operation. For thyroid surgery, the average length of time for a robotic assisted thyroidectomy is 5 hours. The average amount of time for me to do a thyroid lobectomy is less than 1 hour. So there's a difference. Now, there's a learning curve, right? So when you're learning an operation, it takes you longer. And so it's hard to know what are the benefits after you've gotten really good at it. And so, again, I think that there's somewhat of, that raises a whole nother ethical dimension, which is if you keep doing what you already know how to do, you're better at it. Whereas if you do something a little different, it can be more challenging. Now, I think part of the difficulty with this robotic-assisted thyroidectomy is we know we have an operation that's totally safe. The risks of a permanent problem are 1%. On the other hand, if patients say, I really don't want to have a scar that's visible, is that enough of a reason to do something else? No? No. So, and that's where the question is, what's of value to the patient? And so on the one hand, I want to be a sensitive, ethical surgeon, and so I say, well, golly, if it's really that important to the patient, I should be sensitive to that. On the other hand, I don't really know what the results are doing it this new way, because if you have something that has a 1% risk, you have to do many hundreds of them to know if it's as safe, okay? So you can't do 10 and say, hey, this is great. The risks are the same. You have to do several hundred. So it becomes very, very challenging. And we don't have time to go through all of these questions since I'm running out of time, and I apologize for that. So let me just suggest to you that this concept of a surgical innovation committee is something that we're taking very seriously. So we do think that there are innovative operations, and there are things that may be done at an institution that aren't exactly research, and yet we shouldn't just have cowboy surgeons going off and doing whatever they want. And so we are trying to develop such an oversight committee, surgical innovation committee here. There is only one prior model that was used at the University of Toronto at the pediatric hospital for a number of years, although they stopped doing it And why did they stop? Because people stopped sending them cases to review. Yeah, so they had a committee, but nobody said, give us something to review, so the committee disbanded. So one of the questions, again, we have now come to this agreement that we should have this committee. We're trying to, get it going, but we don't really know what are the appropriate standards for deciding if something is acceptable innovation or not. So that does remain to be seen. So in the 2 minutes that I have left, let me make a few conclusions. Now, somebody once said, nobody listens when you give a talk until you say, I have a few conclusions. And then they listen, all right? And so what I've come to do is put about 15 slides in my conclusions. But that's a joke, because we're really going to be done in 2 minutes. So I would conclude from this, and hopefully, the trouble sometimes with an ethics discussion is that you can get so involved in the discussion that you sort of run out of, what is the conclusion, right? So I would conclude a few things. The adoption of new technology in surgery can be problematic. Hopefully you'll agree with that. That although most are in favor of innovation, there's a potentially slippery slope of allowing innovation without any oversight or review. And that all innovation is not research, but deciding when it crosses the line can be difficult. And finally, wholesale acceptance of all surgical innovation, wholesale acceptance that all surgical innovation is research and requires IRB approval, I think, would slow down innovation. So I don't think that that's the best approach, and that we don't want to slow innovation. We want to allow it to continue, and therefore I would argue we need a new mechanism for formal review of surgical innovation, and that will be something that will be critical to the future of surgery. So with that, I do very much appreciate your attention and your participation, and so I hope you enjoy the rest of, yes, please return these on your way out.